Great. Well, thank you so much for joining us on your lunch hour today. We appreciate you taking the time to drop in. We've prepared a little bit of a slide presentation just going over some of the high-level changes that have occurred for the virtual care services. So we'll just take a run through this really quickly. This will be posted after this session so that you can have access to it and get into the particulars. There's a few dense slides in here that I have provided from the OHIP website themselves that cite some examples. So we'll just kind of quickly go over them, but they'll be available to you after the session for further review. So as I'm sure you're all aware by now, as of December 1st, we've moved to a new model for billing virtual care services. Virtual services are now either defined as comprehensive virtual care or limited virtual care. The way that OHIP is defining an existing or ongoing patient relationship is based on the patient's billing history. So if the specialist has had an encounter with the patient in the preceding 24 months, that establishes an existing or ongoing relationship. There is language in the schedule of benefits that allows for a K083 or an OTN visit within the preceding 24 months to be sufficient to meet that requirement. However, we have heard from the OMA, and this came through physicians reaching out to their OMA representative, and the OMA has confirmed in a couple of cases that specialists have to see the patient every 24 months in order for virtual care to be eligible. So this point still needs to be tested in terms of what we see in accepted claims from the Ministry of Health, because it seems to be contrary to the provision in the schedule that allows for the K083 and the OTN visits. And it seems to be contrary to the examples that OHIP has published on their website. So this is still to be determined, but this is the official guidance at the moment. So some of the examples that OHIP has provided are very specific. In this example, a dermatologist is referred by a family physician because of a chronic skin eruption. The dermatology consultation is conducted by video, and they suggest that for that specialist, they be claiming a full consultation with K300, indicating that the visit occurred over video. So this would kind of immediately contravene their statement that you have to see the patient in person. So I think that there's a lot of gray area so far that needs to be further honed in on, and some points that need to be clarified on OHIP's point. So this is taking that situation a little bit further, where after 24 months, the specialist has only followed the patient in a virtual setting. And so the question is, what should the specialist do if ongoing care and maintenance is required? So in this instance, they're saying that the specialist can send the patient back to the family physician, where the family physician can make the determination if a repeat referral is required. This repeat referral is only eligible for virtual consultations, and different guidelines would have to be followed for in-person consultations. But as long as that family physician requests that the specialist continue seeing the patient, that is deemed sufficient for the physician to go on with their virtual visits. Alternatively, the specialist may determine that the patient does need to be seen in person, and that in-person encounter would qualify for another 24 months of virtual care and follow-up. And then there are the alternatives of claiming limited virtual care because there has been no reestablishment of that ongoing relationship. Or it may be an option that the specialist is no longer required and the family physician takes over the ongoing care of the patient. In another example, we see a a pediatric patient who was treated for clubfoot by an orthopedic surgeon. They were seen in person 6 months ago. The surgeon agrees to conduct a follow-up visit using a verified video solution, and the parent has no new concerns. So this would qualify because the orthopedic surgeon had seen the patient in person, so it then qualifies them for 24 months of virtual care. And in another example, a geneticist who has provided telephone assessment before December 1st and billed that as a K083 is going to have a follow-up video consultation, and that K083 is deemed sufficient to establish that existing relationship. And so you could claim the full amount via video, or if doing the follow-up over phone, you would be paid 85% of the in-person rate. So how do you bill for the comprehensive virtual care? Once you've established that you do have an existing or an ongoing relationship with the patient, the virtual care component is claimed with the appropriate consultation or assessment code for your specialty. There are some counseling services that can also be claimed via this method. And any premiums that the consultations or assessments would be eligible for, or many of the premiums would also be payable for virtual care. So in addition to that consultation or assessment or counseling code, you would need to supply the modality indicator or some indication of the patient being seen via video or via phone. So the code for video visits is K300, and that's paid at the same rate. Now, they have put a provision in that any video consultations or assessments have to be performed over an approved platform, and you can find a link to that on the OHIP website. Ontario Health has a very interactive list about which software platforms need to be used in order to qualify for the K300. And then again, just to note that telephone visits are now paid at 85% of the value of an in-person visit. Where no existing relationship exists between the patient and the physician, the limited virtual care codes are A101 if the care is provided by video, and 102 if provided over the telephone. And as you can see, those are drastically reduced rates. So this has created a bunch of other changes related to virtual care. The main ones being that OTN billing is no longer accepted by OHIP. That has been rolled into this virtual care framework. And so too have the COVID-related K codes. So all of those codes have been discontinued, and all of those services are now considered virtual care and should be submitted with the appropriate assessment or consultation and the modality indicator. There's a provision that virtual care is eligible for workers' compensation claims, but there is a note that they are not eligible for reciprocal medical billing claims. So this means if you're evaluating a patient who has provincial insurance from one of the other provinces, your options are to submit a paper claim directly to the patient's home plan, for example, if they have Quebec insurance, or you can charge the patient directly, and there's a special form to do that. So we won't go through all of these, but I thought it important to include the fee codes that are available for video only or the video and telephone. So as you can see, it's most often related to the consultations are accepted for video only, and assessments and some counseling services are accepted for video or telephone. And then there will be some links to some additional resources that you can have access to once this is posted online, so that you can read up for further information if you'd like. So with the groundwork laid, I thought it more important that we hear from you and how this might impact your practice and the changes that you're encountering when you're evaluating patients virtually. So Does anybody have any questions or examples they'd like to bring forward? Dr. Ritzman?
Oh, hey, Melanie, thanks for the presentation. I had a few quick questions. One of them was around the definition of comprehensive. And so I hear what you're saying, and I was reading through I guess the general preamble's been updated, right? And I thought there was kind of a three-step with an or in between each of them. So there was the direct encounter, there was the patient enrollment in the consent to release personal health information, and then there was the consultation by a specialist within one of those accepted appendix. What was that, Appendix J or something like that?
Yes. Yeah.
And so I guess my question is, so I'll give you an example where this often comes up for us, is that we'll have a new referral for an ALS patient who's severely immobile and impaired, and they're in Peterborough, and they say, look, I can't afford $1,000 to drive back and forth with accessible transportation. I would like to be seen by the multidisciplinary team. And so then we're scheduling a video visit initially. And so we're just seeking clarity, because I've had this has come up across some of our ALS Ontario talks too, of people saying, I can't make $10 on an hour visit. So I don't know if my interpretation is correct in terms of that, that Appendix J does allow that even if you've never met them before, because they've just been diagnosed or referred, if you're in that Appendix J and you're providing the video, it could still be acceptable to prove comprehensive.
So this is where the conflicting information comes in. In the general preamble, it does strongly lean towards having had an in-person visit with the patient. However, in the examples that OHIP has posted on their website, a couple of which that we've gone over, it clearly states that as long as the referral comes to you, that initial consultation can take place virtually. So as I said at the beginning, this is something that we'd really love the opportunity to test, because we won't really know how OHIP's going to decide on the case-by-case basis without some claims going in to see how they're going to process that claim. And it is within the purview of SEAMO billing services that we will, if in that case it's rejected, we will provide documentation out of the patient care system in support of that. So what I have been suggesting to physicians is that if the video consultation is requested by the patient, especially, that it be noted in the clinic notes for that encounter. And that may go a long way towards swaying OHIP to our way of thinking. Okay.
Thank you. And then my second question is, are you going to send out a list of those accepted platforms? Because people have had to adapt over COVID, and certainly, OTN, I presume will be on that list, but there's others that people have had to use just to try to meet the unique circumstances of their clinics. So for example, like I know SEAMO coordinated Reacts. And so I don't know, it'd be nice if we could just be sent out from SEAMO billing, like a list of the accepted platforms.
The list of platforms is constantly being updated, so I wouldn't want to send out something that is going to change tomorrow, but I can definitely send out the link to the approved list so that you can access that.
All right, thank you.
You're welcome.
And Mel, we just have a question in the chat whenever you are ready.
Yes. So Dr. Kung has asked, so to send the billing to you, we would send you as usual the visit code, diagnostic code, premium if applicable, and then the modality indicator, such as K301. And yes, that's exactly what we would require. So we would need the level of consult or assessment that you're providing, the diagnostic code, any premiums. And if we have permissions from you on file to add those premiums when we see a valid combination, we will continue to add those for these types of visits. And then, yes, some kind of indicator to just say if it's telephone or video, or the K300 and the K301. That would be perfect. Any other questions or examples, scenarios that you'd like to run by us? Dr. Matthews?
Yeah, hi. Thanks, Melanie. One of the challenges we're facing in the palliative care clinic is we have a shared clinic model. So there's day-to-day variation on who is in the clinic, and we see each other's patients depending on the schedule. And so in palliative care clinic, it's very common that a patient who's scheduled to be seen will call in and say they're not feeling well that day. So can we switch from an in-person visit? We try to make it all in person, but it's common that they'll call and say they're not feeling well enough to come in. So can we just switch to a phone visit? So the challenge is if it is scheduled in the clinic of someone who's never previously met this patient, we can't bill our usual billing code, the K023, and we have to bill an A301, which is, I think it's just $15 or something. So in the last month or so, we've had many cases where we spend an hour, maybe even more than an hour, talking to a patient who is known to our service. So there is one of our colleagues has been following this person in person, has met with this person, and because we're a shared care clinic, I might see this person today, but there's over the phone, and I've never met them in person, and I can't bill for the amount of time that I spend with the patient. It's just the A301. So that's one of the challenges that we've been facing, that and I'm not aware of there's any way to go around that. So what we've been trying to do is, if they request for phone visits, we see if they can wait a few days until they can be booked into the clinic of the physician who has seen them in person before. But otherwise, we just kind of take the kind of loss in terms of our time. So I don't know if you've got any thoughts on that.
So there are some provisions in the general preamble where, again, I would suggest sending these as telephone visits. So there are provisions for if the patient absolutely refuses to present in person, and a phone visit or a video visit is all you're left with. So it may be something that if you include in your clinic notes for that day, we may be able to make the case to OHIP that it was due to the patient's illness that they were unable to attend in person, and that at the patient's request, it was converted to a telephone visit. Now, again, I can't guarantee the success of such a strategy, but there are provisions in the schedule that allow for that type of conversion at the last minute. And I would really like to pursue those with OHIP to kind of make the case that this model that they've put forth doesn't really capture all of the different scenarios that you're going to encounter across all of the specialties. It is a complaint of this framework so far that I've heard repeatedly, that it seems to favor general practitioners instead of specialists, and it will favor some specialties over others, palliative care being one of the disadvantaged groups for sure. Geriatrics would be another, because the patients just don't have the technological savvy to participate in video interviews and encounters. So we'd really like the opportunity to work with you to see if we can make these cases with OHIP as precedents about why the sudden conversion is necessary and the best case for the patient.
Great, thanks, Melanie. That's helpful.
No problem. Oh, Pradeep has very helpfully put the link in the chat if you can access that to the verified solution list at Ontario Health. So that will contain all of the approved video conferencing software that is currently on the list. Are there any other scenarios or questions that people had?
think perhaps we can wrap it up, Melanie. I think I'll just say for the sake of the recording and people who can't access the chat that, oh, sorry, Dr. Ritz has another question.
Yeah, that's okay.
I'll let him
Thanks.
go ahead.
Thanks. I guess thanks for sending along that link. So for example, I don't initially see Reacts on that list, which I know was one that SEAMO had helped get us access to initially during the pandemic, so we could sustain clinics. If I guess I'm just looking for guidance. So I'm already, having to individually still email patients, for example, with ALS to book the appointments for our clinic, and I have to use both Reacts and OTN. So if I'm not able to do that any further, would there be an initiative on SEAMO front to try to look at other ways or to have a few different platforms that are approved available to providers?
That is a great question, and I'm happy to bring that up to the SEAMO group as a whole and see if there's a solution that might be preferred or provided for SEAMO-funded physicians.
Great. Thank you, Melanie.
Mm-hmm.
Seeing no other hands, I'll just let everyone know that this recording and Melanie's PowerPoint presentation are going to be available online, and SEAMO Billing Services clients will have access through the newsletter that goes out in March. It'll also go out in the general newsletter that goes out from SEAMO next Thursday, February 2nd, and available on our website for anyone to access if they're unable to join us today or want to refer back.
Great, and thank you so much for doing that, Sibylla. That's going to be a great help. Well, I haven't seen anybody else log in, and if there are no further questions, we won't take up any more of your time. If questions come to you after this session, please feel free to email me directly. I'm in the global address book at the KHSC site. And if we don't have an answer for you, we're more than happy to approach OHIP to obtain any clarification that you might like on these points.